40 years, female patient having shortness of breath on exertion and occasional but recurrent palpitation and shortness of breath, but gradually increasing. Just ECG shows a right ventricular hypertrophy, taller in V1, and chest X-ray also shows the cardiac shadow enlarged in transverse diameter. Now, just we like to go for echo. It's a parasternal long axis view. Shows is very much obvious. Interventricular septum is thickened and RV free wall also thickened and cavity is reduced. And also there is a hugging of the two wall, septum and so posterior wall. So okay, now just parasternal short axis view at the level of papillary muscle. It shows there is a bouncing movement, but flattening of the interventricular septum. That means we can gaze there will be right-sided volume or pressure overload. Okay, just we go for apical four-chamber view. Okay, there is a movement, there is a bulging to some extent towards the from right to left atrium, interventricular septum, and there is seems to be right atrium is dilated if you compare with the left atrium, and also if you compare with the left ventricle, right ventricle, if when the almost equal size the left ventricle and the right ventricle, that we can gauge the right ventricular enlargement, but here there is almost the double. So put color. There is a significant tricuspid regurgitation. Significant tricuspid regurgitation. Okay. Now we go for apical parasternal short axis view at the level of great vessel. Here very much pretty good looking origin of the, almost always I very much happy to see the origin of the coronary artery, especially the right coronary artery origin or ostium, and sometimes the left main coronary artery. In this view is very much looks pretty good, this one. And just resolution, reduce the resolution power, and just put the color Doppler in the, here shows the mosaic. Nice mosaic. Now put the CW over the pulmonary valve. So there is the two type of spectral display or envelope. One is the dagger shape, yeah. Another is almost a bullet shape. See here. Just we can scale, use scaling, then we can complete spectral display. Now again, yeah. PR as well. Just to measure pulmonary valve VTI, PB-VTI, just start from here, from base to just border delineation. Okay. So velocity 5.56 meter per second, and the maximum pressure gradient 124 or around 125, mean pressure gradient 57, that means around 60, VTI 125, 125 centimeters. So severe pulmonary stenosis. Severe pulmonary stenosis. So there is a pressure overload in the right side and also peer as well. একটু ব্যথা লাগবে বাবা, একটু ব্যথা লাগবে, এটা ভালোভাবে দেখতে হলে একটু ব্যথা লাগবে আর একটু শরীরে হাড্ডির yes 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 just you can see the movement of the pulmonary valve. There is a reverse doming, systolic doming. Here infundibular and also pulmonary valvular stenosis. This is the dagger shape infundibular, 45 on an average 45 millimeter mercury, and just we can see significant tricuspid regurgitation. Just we have to see the subcostal window with subcostal window and apical fourth chamber view. Due to significant tricuspid regurgitation, inferior vena cava to some extent distended. And the interictal septum intact. In this view is very much important, the interictal septal defect localization, detection and localization or type of interictal septal defect. We can see the not only here the superior inferior vena cava, also we have to see the superior vena cava as well. Here the superior vena cava, this is the inferior vena cava, this is the hepatic vein. If when the very much severe tricuspid regurgitation, in that case there is a sign, deer horn sign or playboy sign, but here not so much classical. So at first, when the are going for echo, you have to auscultate or examine the clinical examination and patient getting the clinical information. And without clinical information, without auscultation, without ECG, chest X-ray, complete diagnosis, it's not possible. It's very much important. Each and every patient when doing the echocardiogram, clinical examination, at least the precordial auscultation is very much important. And his or her ECG, recent ECG or previous ECG, recent X-ray, previous X-ray, you have to correlate. Without correlation, it is not possible to make a complete diagnosis. So in that case, there is a severe pulmonary valvular stenosis and infundibular stenosis as well. But there is no VSD. There is no VSD. This flow due to RVOT obstruction, not VSD. Sometimes looks like the VSD, but not VSD. Apical, again apical fourth chamber view, we just put the color just from apex to base, interventricular septum there, but there is no passing of color from, and there is no jet mosaic formation. Just only tricuspid regurgitation due to pressure overload in the right side. So RARB dilated and the septum is flattening of the septum, and there is a, when the in the parasternal long axis view, there is a hugging of the both wall due to compression of the interventricular septum, the pressure rise in the right atrium and the right ventricular as well. Thank you very much. Thank you all.